Jim, my name is Ben Wright. I'm a consultant neurologist. I work at the Queen Elizabeth Hospital in Birmingham and act as the principal investigator for the adult arm to this clinical trial.
Fantastic, thanks, Ben. So between us, we're going to give an update about the clinical trial altogether. So I'm just going to share my screen and check this is going to work all right. Let me just give me a minute. Right, okay. Tracy, can you see my screen all right? Yeah, fine. Lovely. Okay, so this is a three-way presentation that we'll do as we get to that part. So what I'm going to cover is a little bit similar format to last time. The justification why we're doing the trial, why sodium vaporate, what participants are being asked to do, where we're at the moment, and then of course what happens if any new treatments come along or at the end of the trial. So just to start about why we're doing this trial, this really goes back to a survey we did of patient support groups, the Snow Foundation in America, the Spanish Wolfram, the French Wolfram, and WSUK, asking what symptoms families ranked the most important. And each patient support group ranked vision as the most important one, that if anything could be done, it could be something to do for the vision. So we took that as a starting point to try and design a clinical trial with vision as an outcome. Thanks to Professor Tammy Hershey, Stephanie Snow-Gabel and colleagues at the Wolfram Research Clinic at St. Louis in Washington, they very kindly shared their vision data of about 24 people with Wolfram followed up over a number of years. And what you can see on the x-axis is the age and the time people were followed up, and on the y-axis what you can see is the vision. And a vision of 0 is 20/20 vision or perfect vision, and a vision of 2 is ability to count fingers only. And what you can see in the middle red line is the average rate of progression of vision change over about 10-15 years of that time, which we can measure really accurately because there's good vision charts. And the bottom red line is what you can see that we're trying to see if we can slow it down by over half, as we think would be a meaningful improvement for people with Wolfram if we could do that. So we can measure the progression of vision well. And the other reason for doing vision is because it's a marker for what might be going on in the brain underneath. And what you can see here is a magnetic resonance image of the brain on the left-hand side of a healthy young person. And on the left, you can just about make out the nose. And on the right, you can just about make out the back of the head. And on the right-hand side, a young person with Wolfram. And the key difference is this thin string-like structure down the middle called the brainstem and the spinal cord, which is a bit thinner than it is on the left-hand side. And then that sort of cauliflower-shaped organ at the back, the cerebellum, which again is a bit smaller than it is on the left-hand side. So we think vision loss might be a marker, or is a marker, for other changes going on in the brain. So why sodium vaporate? So it's been a drug that's been around for probably 60 years. This is a slide kindly shared with me by Professor Mark Pashonsky, with over 3,000 papers published about it. It's been used for epilepsy for about 40 years. It's known to get into the brain, cross the blood-brain barrier. It's known to actually be a protective agent for brain cells, and it helps brain cell growth. And it also reduces endoplasmic reticulum stress, which we know is one of the factors causing Wolfram in this area. So there's a long track record really of this being a neuroprotective agent. Specifically for Wolfram, Fumi Arano, our colleague at St. Louis, published a paper going 12 years ago now, looking at sodium valproate on cell models of Wolfram. And what he's showing is that with valproate treatment, he could increase the expression of the Wolfram protein, which would be a good thing for people who still make some. But at the same time, it stabilized endoplasmic reticulum stress, which is the flat line on the left-hand side. So that was the first indication that sodium valproate might be good in Wolfram. And then Professor Sulev Cox in University of Tartu 10 years ago published a mouse model of Wolfram syndrome and looking at the effect of sodium valproate on diabetes. And for these different pictures, on the x-axis is the time when mice have been given a sugar or glucose tolerance test, and on the y-axis is how high the glucose goes. And if you just look at the right-hand graph there, these are Wolfram mice where the Wolfram gene has been knocked out. And the green and the black lines are the Wolfram mice who've just been given saline or diazepam control, and their sugar levels go really high after about 30 minutes of a sugar load. Whereas those who've been treated with valproate, in the red lines, they don't get nearly such a high result. And it would suggest that sodium valproate would be good for the diabetes aspect of Wolfram syndrome. And then work done in our lab by Dr. Małgosia Zatyka and Dr. Dewey Astuti shows on the left-hand side that sodium valproate in increasing concentrations can increase the expression of a cell cycle regulator that stabilizes neuronal cells and gives them time to recover from stress, each of those. And on the right-hand side, a marker for cell death got better with sodium valproate. So in control cells and in 2 models of brain cells of Wolfram, all of those with increasing levels of sodium valproate, cell death reduced, got better. So nice scientific evidence that sodium valproate might help here. Last year, a further paper was published by another group showing that sodium valproate can reduce cell stress in a pancreatic beta cell model of Wolfram. And on the left-hand side, you can see in the black lines, black bars, untreated cells, and in the grey bars, cells treated with valproate. And that's a measure of stress, and the cells treated with valproate have much less stress from there. And on the right-hand side, it's a measure of cell death. And again, the black bars show untreated cells where there's quite a high level of cell death, but in the sodium valproate bars, the grey bars, that's much reduced. So it looks like it has a protective supportive effect. And then finally, thank you very much, Professor Mark Peszonski, who's on the call, and Dr. Letitia Aubrey, who've generated some beautiful data that's now been accepted for publication in the American Journal of Human Genetics. And on the left-hand side, what you're seeing is photomicrographs of brain cells, neuronal cells, derived from white blood cells from patients with Wolfram. And there are 2 different models, WS2 and WS5. And on the left-hand side, these thick red lines that you can see on the graph here, or on the picture here, are sort of thickened neuronal bundles that are quite abnormal. You wouldn't expect to see those. And there's some marker, or maybe a marker, of the pathology in Wolfram. And on the right-hand side, in the 3rd panel across, you can see they've gone by treatment with sodium valproate at a reasonably high dose, suggesting that sodium valproate may prevent some of the brain damage in Wolfram syndrome. So that was a bit of background really about the evidence that's accumulating to suggest that sodium valproate might be a possible treatment to delay the progression in Wolfram syndrome. So moving on from that, an important thing people want to know is what's the side effects of sodium valproate. So these are expressed as common, which would affect more than 1 in 100 people, or very common, affecting more than 1 in 10. And what we know about side effects is it can cause abdominal pain, can cause hair loss, but it's usually temporary. It can reduce the blood count sometimes, cause concentration problems, and it can affect periods and feeling of sick. And colleagues like my colleague, Dr. Ben Wright, are very familiar with this medicine. It's used a lot for epilepsy and things and know the side effects very well. Uncommon side effects can affect bone metabolism or kidney function or pancreas function, and very rare ones would be liver function. The most important side effect about sodium valproate is that you mustn't give it if you're pregnant, because it could harm the unborn child. So it's not without side effects, but like every drug is, importantly, we've got decades of experience of using it, and it's been used in many thousands of children and adults over the last 40 or 50 years to treat epilepsy and other diseases, bipolar disorder. So what are participants being asked to do? So we've set up a clinical trial with 2 arms to it to find out whether sodium valproate is effective and safe to slow down the progression of Wolfram in children and adults. And there are 2 arms of it. One group of participants has sodium valproate, and a smaller group of participants has placebo or dummy drug. Everybody taking part is put into one of those two groups at random, and neither the doctors nor the participants are allowed to know which medicine they're taking, because they should look identical until the end of the study. And it's an international study, so it's running across the UK, Spain, France, and Poland. The things that people want to know from this are that, and I'll read out parts of this. First of all, participants, it will involve extra visits to the hospital, but participants who take part, if they change their mind, they can stop at any time, and it doesn't affect how we look after them. That's not a problem. 2/3 of participants will receive the study medicine, and 1/3 will receive the placebo. So people taking part have a 2 in 3 chance of receiving the study medicine rather than the placebo. If the study medicine works, it'll be used to treat people with Wolfram syndrome, and that people will continue to be looked after in our service just like they always are, whether people take part or not. So there are about 5 stages to this. At the first visit, we do some baseline tests to check participants are eligible. We do a baseline brain scan and a sugar test and some walking and balance tests, and ask people to keep diaries about their mood and how they are. The second visit, people are randomized to start either the study medicine or the placebo. And then there are safety follow-up visits at 6 weeks and 12 weeks to check people are well, and that it's not causing any adverse events. And then in the maintenance period, we see people every 6 months to do an eye test. And what we want to do is to measure the vision and see how that is changing over time. And of course, we want to know is the change in vision less in the people on the sodium valporate than the people on the placebo. But we also want to see if there are benefits in other aspects like hearing, balance, walking, and of course diabetes as part of it as well. And the final check at the end of the treatment is to check that people are well as they stop taking part in the trial. So this is a cartoon that we use in medicine to demonstrate what the trial is, and it shows you that there's a screening period, then 4 weeks, then people are randomized to sodium valporate or placebo by the toss of a coin. And at the bottom you can see V stands for visits. You can see there are 11 visits in total, and in between that, TC means telephone calls. So we have follow-up telephone calls to check people are healthy as well. Throughout that, we try and do vision tests and MR scans to see if we can map any changes to the vision with what's happening to the underlying brain. And remember, this is a study to try and address the brain and the vision aspects more than the diabetes aspects of Wolfram. So how's the trial going at the moment? So a couple of slides here. First of all, it's important to explain that to set up an international clinical trial does take a long time. From the design of the study, getting a sponsor, so the sponsors here is the University of Birmingham, getting the funding, so the funder is the UK Medical Research Council, getting the ethical approvals, so this has to be approved by the Health Regulatory Agency in the UK and the equivalent bodies in Poland, Spain, and France. Making the medicine and making the placebo, so we've had to get the medicine from a company called Walkhart in North Wales, and the placebo, which is made in the clinical trials unit at Guy's and St Thomas's Hospital. Getting insurance for the trial to make sure that everything is covered okay, and then setting up each individual site. And only at that point are we allowed to open to recruitment. So I know this can be a very frustrating process for people who'd like to take part, but it's all done to try and ensure safety, that we don't do anything that would harm anybody. That's the most important thing. Right, so the trial participants so far are that we have 57 participants taking part. The age range is from 6 years of age, and there's no upper age limit, which is really good news. Overall, in the trial, we've got about 30 males and 27 females, so it's half and half. And then you can see colleagues in France, Spain, and Poland who've done a fantastic job in recruiting patients. And I know Dr. Hema Esteban is on the call I think we're incredibly grateful to her, because with her and her Spanish participants, she's recruited, I think, at least 16 participants at the moment, which is fantastic. Between our colleagues at the Queen Elizabeth, the Children's, and Spain, and I think France, we have further patients to come, and we believe that we will reach close to 64 patients at the end of October, because we've already consented some. All of the results are being sent to an independent data monitoring committee, and they can see all the data and which patients are on which treatment. And if there's any sign of that the treatment's unsafe, or it's not working, or indeed it is, it's an outstanding result, they will be able to let everybody know and stop the trial at that point. And then there's a big thank you to Wolfram Syndrome UK, because they've really helped with supporting UK families with travel and accommodation. And I can say we wouldn't have been able to deliver this trial without Wolfram Syndrome UK. So a massive thank you for their support. At that point, I'll hand over to Ben, just to update on the adult side, and then Dr. Renuka Diaz for the children's side. Yeah.
Thank you very much, Tim, and as always, many congratulations to you to getting this off the ground in the first place. The other people need to thank really are the participants who have chosen to give up their time, and also any family members or people who've come with them. These visits are, there are lots of them, and Birmingham's not central to everybody. We have obviously had problems in terms of delivering the trial amidst a COVID pandemic, which no one really could have foreseen. And we have altered the visits accordingly to really minimize the time people need to spend at Birmingham in the hospital environment. And we have gone to immense precautions, understandably, to minimize any risk. And, you know, for people to first of all take part in a trial and also to take that on board really is, I take my hat off to those people who have taken part. Obviously now things are somewhat easier, and we are still maintaining necessary precautions, face masks and distance, and where we need to. As Tim says, we've recruited 10. We have seen more than 10 people. Unfortunately, there are some people who were unable to be recruited. Hopefully that number will go up by 1 by next week. So we'll have a further person participating. And I've also worked with the research nurses who make sure that all the scheduled events take part during the trial, and that these are communicated back to the patients where needed. I think that's perhaps all I need to say at this time, but obviously there'll be time for questions at the end if I haven't covered everything. So I'll hand over to Renuka.
Thank you. Oops. Yeah.
That's all right, Tim. That's fine. So yeah, I think I would echo what Ben has said, that you know, it's a huge thank you to everyone who has chosen or wanted to take part in the trial, but either has taken or hasn't been able to take part because of other reasons. And has, as Ben says, a huge thanks to the CRF team as well that have supported this work at BCH. So in Birmingham, we've actually recruited 13 patients so far, and we've potentially got another 1 or 2 patients to come through before trial recruitment ends in October. The split is slightly different to the overall picture. So we've got 5 boys and 5 girls. And we were the first site to open for the trial. So we had 11 young people start treatment in 2019, and then 2 commencing in 2021, with a pandemic intervening, which stopped us recruiting anyone for obvious reasons. Of those 13 patients, 5 have actually withdrawn, 2 for patient choice. And as Tim said previously, trial participation is completely voluntary, and we make no distinguishing, we don't distinguish between those who are in the trial and who aren't in terms of their medical care. 2 had some adverse events, primarily around hair loss that they weren't happy with, and one had a completely separate medical issue. So yeah, in total we've got 13, potentially 15 to come on. Is there a second slide?
Yeah.
Tim? Yes. Okay. Thanks, Tim. So generally, actually, the sodium valproate is well tolerated. We've had to reduce some of the dosing for some participants because of the GI side effects, GI issues that Tim mentioned, and the hair loss. And for a couple of patients, tremor has been an issue, hand tremor in particular. But generally, it's been tolerated well. Next slide, please, Tim. Because we were one of the first sites to recruit, the majority of patients who were recruited through BCH will complete their study protocol in early 2022. So the majority of other sites will have patients ongoing till 2020. The majority of their patients will go on till 2024. And I've been asked by a number of families what will happen in 2022 when the trial finishes. And effectively, what will need to happen is that an independent trial oversight committee needs to make a decision, and we're going to try and hopefully have that by the end of the year, as to whether patients who would like to continue to take sodium valproate. So you previously wouldn't know whether you were on sodium valproate or the dummy medicine, but you would take sodium valproate at that point, could be offered this by their GP, but it is an unlicensed indication at the moment, so the GP would need to be happy to prescribe it, if that makes sense. And I think that's all I have to say, and I'll hand over to Tim.
Thank you, Renuka, and thank you, Ben. That's really helpful at the moment. Hopefully you can take some questions at the end as well. So in terms of new patients, new treatments coming along, what happens if a new treatment is available? So we're following closely all developments about Wolfram, which is of course really exciting, and a paper was published recently by Fumio Arano and others about dantrolene in Wolfram a couple of months ago. If any new developments occur that might affect the treatment, or a new treatment become available, we'll obviously tell participants straight away, and of course that'll also be through Wolfram Syndrome UK and Tracy Lynch as well. If that was to happen, it would then be up to participants to decide if they want to continue in this study or to stop. What unfortunately we can't do is, it's not possible to take part in 2 clinical trials at the same time. So that obviously, if a new trial was to start, then one can only be in 1 trial at a time. If a new treatment becomes licensed for use in Wolfram, and that means that all the safety checks have been done and it's been shown to work, then participants will be offered the new treatment irrespective. And of course, we're all hoping that at some point a new treatment will become available. And I'm hoping obviously that this treatment, sodium valproate, will do so. What happens at the end of the trial? Okay, so this is the procedure. We've got a trial statistician called Dr. Victoria Homer, and she's working under a team of statisticians, including Professor Cindy Billingham as well. They look at all the data, and they know who's been taking the sodium valproate and who's been taking the placebo. So they find that out first of all, and that's for all 64 patients. They then compare the rate of progression of vision loss between the 2 groups. And what they're looking at on that right-hand side is the red line is the rate of progression that we can predict based on the St. Louis Research Clinic, and kindly shared by Dr. Hochul and Tamara Hershey. The green line is what this study is powered to detect. If we can slow that rate of vision down to that much or even better, if the rate is better following that green line, or even better in the control group, in the treated group, then it looks like sodium valproate works, and hopefully it is safe. Then we work with a pharmaceutical company to ask our regulatory agency, the MHRA, to license it for use in Wolfram. And at the same time, we work with the European Medicines Agency and the FDA in America to get it licensed for use in Wolfram in Europe and in America. And then we can offer it to all people with Wolfram. So that's the process. That process can happen quite fast, particularly if a medicine is shown to be quite effective. And I've seen it happen with other medicines for other things within less than 6 months. It can happen quite well. The key question: can trial participants take sodium valproate after the end of the trial? So the answer from the clinical trials group is no, because it's not yet licensed to treat Wolfram syndrome. Sodium Vaporate should only be prescribed for a recognized indication, and the two recognized in the UK, and Ben will correct me if it's others, is epilepsy and bipolar disorder. So that's what we're allowed to prescribe sodium valproate for in the UK outside a trial. However, we understand that some participants will feel strongly about this and may want to have that. And as Dr. Renuka Diaz says, we will take participants' views to a trial steering committee, and it would be helpful for participants if they wanted to feedback to Dr. Diaz, Dr. Wright or myself, or to Tracy Lynch and WSUK, so that we can collate views for when the trial steering committee would meet hopefully later this year. So what now then? This clinical timeline shows really when we started back in about 2011 through till where we are now, 2021, with the last patient almost recruited. The Data Monitoring Committee meets about every 6 months and reviews all of the data. If at any stage it should be shown that the treatment is not safe, they will stop the trial. If at any stage it shows that the treatment is clearly not working, they will stop the trial. Otherwise, the trial is likely to continue until the last patient has finished, which will be in 2024. And then we will be able to share the trial results with all of us as investigators and with patients who are participants. So that's where we are. And my final slide really is just to explain it is a big undertaking to deliver an international clinical trial. And what I put on here is, on the left-hand side, the clinical trials team. So this is led by our trial manager, Darren Barton, senior trial coordinator, Sabrina Cronier, Amandeep Marley, and then Victoria Homer, who's our lead statistician. And then other people here to pick out is Dr. Heather Rose and Andrew Peat, who've done a great job in being able to actually collect images from patients in 4 separate countries in the UK, in Europe, and put those all together. And I don't really think it's been done before for a rare disease. So it's really valuable, and at the end of the trial, we'll be able to share these with our colleagues in St. Louis as well, Tamara Hershey. On the right-hand side, the international collaborators, and I know Hema is on the call as well, so incredibly grateful for their support in recruiting families for this, and the patient support groups, particularly Tracy and Wolfram Syndrome UK, who've funded a lot of the travel for the patients here, and the I Hope French Wolfram and Snow Foundation, who funded a lot of the research that enabled this trial to take place in the first place. And then in the clinical research teams, the neurology team at the Queen Elizabeth, Sarah Darrowell, Sarah Harris and Amy Price have been absolutely fantastic with our adults participants, and Michelle, Rachel and Josie absolutely brilliant with our children's ones. And then the trial steering committee is Professor Mark Pashonsky, who chairs it, who's got so much experience in these sorts of disorders and rare diseases with our other UK colleagues and Tracy. And the laboratory team, Malgosha Zatika and Dewey Asuti, who did a lot of the groundwork for this as well. And then finally, the clinical team who helped look after the patients, Talia Dewhurst and Marie McGee and Susan Gleason, absolutely fantastic. So with that, it's 1:45. So I'll stop at that point. And then Tracy, hopefully that should be okay, and we can take any questions if there are any between us.
Yep, wonderful. Thank you, Tim. So one of the questions has already been answered, so that's quite handy. That was about what's happening after the when people come to the end of their trial period. So that one has been done. Some of these are a case, I think, of going to have to wait because you haven't yet got the data. And you have sort of touched on these during your presentations. So I'll find one that hasn't sort of been done. Someone says, how long will sight last for a person with WS? Can any doctors tell them? And if so, and how could the drug help? How could valproate help?
Okay, I'll try and start this, and then I'll probably hand over to Ben and Renuka to answer as well at the moment. So we did some follow-up studies in the late 1990s, following up from when patients were registered vision impaired to progress to severely vision impaired. So these are the definitions used in Europe for people who've got some sight loss. Vision impaired usually means people who need to read some paper with a larger size font. So if we think about size 18 font or something like that, would perhaps be visually impaired. And severe visually impaired would be people who would need something like a size 48 font, so quite a bit bigger to be able to read on there as well. That progression on average took about 8 years in the studies of the UK patients, and there is more accurate data coming out from the St. Louis Research Clinic coming as well. What we've powered this study is to see if we can double that time, i.e. it would take, instead of 8 years to progress, it would take 16 years to progress. So much slower, and give people useful vision for much longer. I think that's the easiest way I can explain it. Ben, can you help me out here? Is there anything you want to add to that, and then Renuka as well?
No, I think you've got it, Tim. I think the difficulty comes is that we don't try and avoid the question. Is that on an individual patient point of view, and I think as a graph showed, is people have different rates of change. There's obviously some people on your graph where the angle was quite steep between no problem and quite severe problem, and other people who actually flatlined and then it kind of took off. And so I think there's other things perhaps at play here within the Wolfram gene and the genetic component, and I'm sure the effect of the diabetes as well, which together interact, which we have not yet unpicked, which would explain those patient differences. So I think that's where it's difficult to give an individual point of view, but as Tim says, with the data coming through other teams, and obviously through this trial, we'd hope to be able to be a bit more accurate as we can on a general point of view with these data.
Thank you, Ben. Renuka, I don't know whether you want to add anything on that.
No, just I think the two things are, one, that sodium valporate is not a cure for Wolfram syndrome. It is really primarily to try and reduce the progression of this particular aspect of Wolfram syndrome. And sort of carrying on from what Ben said, it is a spectrum. The condition is a spectrum. So as he mentioned, different people will have different rates of progression. So although you can sort of look at a cohort of people and say X number of years for that group of patients to progress, at a single person level, that is very difficult for an individual clinician to predict. The only thing I would also say, and this, Tim, you'll be much better at this than me, it tends to be a stepwise progression rather than a progressive deterioration. So you have periods of plateau and then a reduction. But yeah, that's all I have to say, really.
That's really helpful, Renuka and Ben. Thank you. And yes, for exactly those reasons, this is why you need so many people to take part in a trial, of course, and why you have to follow them up for long enough to take into account the individual variations so that you can look at what the average is doing over that time. And that's what makes it such a long time. But it's fantastic that so many people have agreed to take part, and this is probably the biggest clinical trial in an ultra rare disease internationally that there's been. So it's hopefully there'll be lots of lessons to learn for other rare diseases going forward as well.
Lovely, thank you. I'm trying to pick out the ones that are sort of a bit more relevant to this. I've got one question that's been asked, and it's saying, what are you all doing to advance treatment for Wolfram syndrome? If you can answer, anyone can answer that.
So I mean, there's a couple of aspects. There's the discovery science aspect, and then there's the practical looking after people aspect. I think I can divide it into those two areas, I think, at the moment. In terms of the discovery science aspect, what's wonderful is that there are so many more research groups around the world studying Wolfram than there were 20 years ago, or indeed in 2009 as well. So, and we're so looking forward to getting back to international face-to-face Wolfram conferences as well, and hearing about new research. And it was wonderful to hear Professor Vanya Broccoli last week about the Italian research that was going on as well. Here in Birmingham, we've established a new line of research in a collaboration with Professor Mark Peshonsky and Dr. Laetitia Aubry in France as well. And we're looking at new mechanisms of the disease, including what's called autophagy, to see whether or not we can find additional ways to treat the condition. On the practical aspect, we both Dr. Ben Wright and Dr. Renuka Diaz are also involved very much in actually improving patient experience with Wolfram through the clinical service. And I don't know whether Ben or Renuka, you might want to mention some of that as well, because there have been quite significant improvements in that in the last few months. Renuka, do you want to go first?
So I was just going to actually just add that the other thing that we're doing is we're sharing data with colleagues. So, you know, it's not just individual silos of information in Birmingham or with Professor Hershey's group or Dr. Arano's group. We are sharing data within, obviously, GDPR confines to make sure that left hand knows what right hand is doing. In terms of the clinical service, we have definitely listened to so from a pediatric point of view, patients and their families describing their experience, and have tried to improve things, but absolutely value people's input into the clinical service so that we can continue to improve it and refine it for you.
Great, thank you. Ben, I don't know whether you want to add, because there's been some pretty significant improvements in the adult clinics, haven't there, over the last few years?
Yes, perhaps I'll take the research point first. And, you know, I think, as Renuka says, is that we have our ears open as to what's going on elsewhere. And I think, you know, with this trial model, which, as Tim says, is the largest trial in ultra-rare condition, is that, you know, I don't want to sound pessimistic, but even if it's a negative trial, the fact we're able to achieve an answer to a particular drug lays a foundation to doing such a process in the future if other drugs are show that they may be of promise. And it kind of demonstrates to the sponsors and regulators that we are able to work internationally with colleagues in terms of the process of this. So I think that's a, you know, irrespective of the result, that'll be a really positive outcome from this. And it doesn't mean that we then, if it does work, doesn't mean we then shut up shop. You know, we will continue to look at developments in other areas and work with colleagues to demonstrate that they are of worth. There's a question about whether future drug combinations will be used, and I think you're right. I think, you know, what we've learned through other trials, certainly in neurology, you know, not just Wolfram, but other conditions in neurology, is it probably does need to be a drug combination to affect change in the brain. There's not going to be a single drug which is the magic pill or bullet or whatever to sort things out. It'll be a multi-pronged approach, because people with Wolfram have a multiple number of conditions as a result of this gene change. It's not just one thing going on. It produces a myriad of effects. In terms of the clinics, and yes, we were expanding the service. We've brought in other team members, such as a speech and language therapist, and we had built up, in effect, a plan to incorporate audiology assessments, with then plans to include urology assessment, and we'd also brought in an ophthalmology team as well. Now, COVID, bugger that is, excuse me, has rather kiboshed all kind of energies and attempts, and we've also reverted to a virtual team model at the moment, which has meant we haven't been able to complete the ophthalmology assessments remotely. It's one of those disciplines that you really do need to see the patient there to be able to look at the back of their eye. So we've had to rather pause that sort of development until we're in such a position to look at these things again. And for those people who have come to the clinics this year, we have continued to lead a virtual model for this year, and my intention is that we will return to face-to-face clinics, but probably incorporate a virtual aspect to it, because, as I say, Birmingham is not local to everyone, and there are those people whereby travel and then trying to get out of Birmingham on a Friday afternoon fills them with dread, understandably. But hopefully we will be able to return back to a face-to-face service, and as I say, hopefully be able to continue the development of the clinic. I know Tracy has been very helpful and keen to offer and provide a further form of support outside the NHS through the charity that she leads.
Thank you, Ben. Yes, we do everything that we can to assist now and going forward, as always, with the adult clinics and obviously the children's clinics. So yeah, we're here for supporting in whatever way that we can. Do we have any other questions from anyone? I know a lot of the questions that I've got have already been sort of covered. Answers have been.
There was a question about regulatory approval, and I don't know if Tim can answer this, around regulatory approval in the EU versus the US versus the UK. So my understanding would be that if it's approved in the UK, it's unlikely to not be approved with the European Union, but whether the FDA would have a different stance, I don't know, but Tim or Ben might have a better viewpoint on that.
So just to say is that we've been in some discussions with what's called SMEs, or small and medium enterprises, who do regulatory approvals, who have indicated they'd be interested in taking this treatment, sodium vaporate, through for marketing authorization with the European Union, the European Medicines Agency, and with the Federal Drugs Administration in the States. They normally would go in parallel, so there'd be two submissions would be done at the same time. As Dr. Diaz says, they have different review panels, and sometimes they ask for different bits of data. But in my recent experience, which has been with other drugs for children with type 2 diabetes, they've both been approved within 5 months of the results being published. So I'd be reasonably hopeful, if it's shown to be effective, that the regulatory agencies would be supportive. And they do actually have a fast track process for approving drugs for orphan diseases. So hopefully it would qualify for that. Yeah.
Wonderful, thank you so much. So we're just coming up to the end of our time slot. So as I say, if anyone thinks of any questions once we've come off, then please do email me. It's admin@wolframsyndrome.co.uk, and I'll send the questions off to our doctors, who are very, very helpful and generally reply back very, very quickly, and I'll then sort of post the responses out to the relevant person that's asking. So I'd just like to say thank you very much for giving up your time this afternoon to join us, and I hope you enjoy the rest of your day if you're not coming on for any of the other presentations. Thank you, take care.
Thanks very much, Tracy.
Thank you.
Bye.
Bye.
Thank you.